The level of the dura. Where's the subdural hematoma? Below the dura. Yep. Below the level of the dura. This time I'm going to choose for the subdural hematoma, I'm going to choose to represent the problem or the subdural hematoma on the right side of the page. Okay? So to start with, we have the first layer of dura, that's your periosteal dura, and as you should remember, it is tightly adhered to the skull, especially those suture lines. Okay, so here the dura is actually intact. And then directly under the periosteal dura is that second layer of dura. That's going to be your meningeal dura layer. And again, there's this invagination, forms the false cerebri. Okay, I'll leave that. So this is your periosteal dura. And then underneath that is your meningeal dura. Okay. And does anybody remember what this little space is called? Yeah, that's your superior sagittal sinus. And that's going to be important for this one. Okay. Underneath your meningeal dura, you have your arachnoid matter. And your arachnoid matter is going to be here with the trabeculae. Okay, I'm not going to fill in the right side yet. I'm just going to make normal on the left side here. And this is your normal arachnoid matter with the trabeculae. Underneath that arachnoid matter, we talked about the pia matter being tightly adhered to the CNS. So here's the pia matter that's tightly adhered to all the sulci and gyri of the CNS. Okay, so that would be the normal situation. And I also talked about in this subarachnoid space, which is here, you have the presence of cerebral arteries and cerebral veins. And those cerebral veins drain into the superior sagittal sinus via the bridging veins. Okay, so just a quick review, nothing new. So this is a cerebral vein. And then this is the bridging vein. And this is normal here on the left side of the image. Okay, so everybody see where we are? Nothing new yet. Okay, so what happens is that in a subdural hematoma, it's the bridging veins that rupture. Okay, we'll talk about how that happens in a minute. But what it looks like is you're going to have that bridging vein that would have been, here's the vein that would have been there. Let's look at here's the, and then here's the arachnoid matter here. So the vein, instead of draining into that superior sagittal sinus, there's a rupture of that bridging vein. Okay, and the rupture of that bridging vein is what causes the pooling of blood here subdurally. Okay, so all that red area, that's going to be your hematoma. Okay, and then underneath, just still have your trabeculae that are here. Everything's really compressed. But you can see the size of that hematoma is huge, and it causes severe compression of the brain on that side. Okay. So one of the, yes, Luther. Sure. So we'll talk about more, but what happened is that there's some sort of trauma, a specific kind of trauma that we're going to talk about, that causes the rupture of those bridging veins. So remember I said that the bridging veins are going like this into that superior sagittal sinus, so they're just here. So the kind of trauma is like a rapid flexion and extension of the neck that causes the shearing of the rupture of those bridging veins. And when those veins break, then that blood, instead of draining into the superior sagittal sinus, actually starts to pool under the door. That's the subdural hematoma. Does that make sense? Any other questions about that? We'll talk about signs and symptoms here in a minute. But you can see one of the big differences, and you can actually see it on a CT scan, between the epidural hematoma and the subdural hematoma is the location of the bleed, the location of the blood. The hematoma and epidural is nicely contained between the sutures of the skull, whereas the hematoma, the subdural hematoma, it has no boundaries. It typically happens all the way down the side. Yes, Jonathan?
Instead of rupturing into the sinus, it's rupturing into the
subdural space. Yeah, so the subdural space is really a potential space. It's not a real space, but when blood starts to pool, it starts to pull out. Okay, and again, there's no place for that blood to go. Right? Yes? No, it does not. Nope. Yeah, the trabeculae matter is intact, the trabeculae are intact, but all that blood is squishing the brain pretty heavily. Just kind of comparing and contrasting the epidural versus the subdural, and there's some pretty stuff. So let's talk about causes here. So the cause of a subdural hematoma. The cause is going to be a rapid flexion, anything that causes a rapid flexion and extension of the neck. Okay, so rapid flexion, so that's a check mark is an abbreviation for flexion, and so just a slash is abbreviation for extension of the neck. Okay, it could be a car crash. It doesn't require a hit on the head. Okay, one of the saddest causes is something called shaken baby syndrome. Yeah. Right, so that's when the baby just won't stop crying, so somebody picks him up or her up and they go back and forth like that, and that head is whipping because they don't have any neck musculature. That's shaken baby syndrome, and you can imagine that rapid shear force just ripping those bridging veins, right, out of the superior sagittal sinus. That's what causes the rupture. Okay, so shaken baby, rapid flexion extension of the neck, shaken baby syndrome is an example, and it's caused by a rupture of bridging veins, of those bridging veins that are bridging the cranial nerves, sorry, the cranial veins, the cerebral veins, and the superior sagittal sinus, rupture of bridging veins during that rapid flexion and extension of the neck. Okay, and the signs and symptoms are rapid. So the rapid, as you can, so if the brain, the bleed happens on a bridging vein, you can imagine the amount of blood starts to pool very quickly. This is not like a little meningeal artery that takes time to accumulate the blood. This is pretty rapid. Okay, so this is a rapid progression to non-responsive. Okay, so it's very rapid progression. And for treatment, here it's going to be something called a craniotomy. You know, somebody who's had a subdural hematoma, when they have a craniotomy, what they actually do is they cut off a piece of the skull overlying the bleed. They take the skull and put it in a plastic bag in the freezer somewhere, and that person is walking around with just a skin covering over their brain to allow that swelling to release. Okay. Well, what you will see in the clinic is when that person doesn't have any skull over that area of their brain, is they wear a little blue kind of helmet, like a bike helmet kind of thing. Okay, just for safety. So if you see somebody walking around with a little blue helmet, that means they've had a craniotomy. Ben?
So why does that type of hematoma require the craniotomy and not just the vertical?
Because it's so large. As well as, yeah, it's very large. It's a very large amount of blood that's been moved.
It's just too much for vertical.
Too much for just a burr hole. Burr holes works really well when the blood is contained in that little space between the sutures, but when it's pulled down the side, it's typically like all the way down.
Okay.
And the epidural one you said could be over like a few days. How fast would this one be?
This one's rapid, almost immediate. So yeah, so shaken baby syndrome, that baby's going to show some neurological deficits, possibly going to coma pretty much right away. Yeah.
With like recovery processes, how is it a significantly longer time with a subdural versus an epidural?
So you being a patient?
Mm-hmm.
I think it's going to depend on the patient overall. I mean, some of the, for instance, it's a pretty significant change. That's caused a lot of brain injury. Yeah, some people do better than others, but for the most part, compared to epidural, it's much worse. You know, in full recovery, it's just going to depend on the patient and the amount of blood pulled and whether they got to it quickly enough. But everybody's going to, you'll see a lot of variability. But it's not a little thing. It's a big thing. Okay. Any other questions? So this is a comparison of epidural versus subdural hematoma. Okay, important things to know, and I'm sure you're going to see them this summer. So let's move on. The next, now we're going to compare the subarachnoid versus the intracranial hemorrhage. Okay. I'd like to compare these guys side to side. And again, because I'm comparing them side to side, I'm going to draw my little dots right down the middle to separate them. And on the left-hand side of the page, I'm going to represent the subarachnoid hemorrhage. And on the right-hand side, I'm going to represent the intracranial hemorrhage. Okay. Another pair. Another two we can compare. So hopefully this is becoming rote at this point. We have our skull here. The skull has the suture lines in it. And hopefully adhered to those suture lines, you have your periosteal dura layer. Okay, so here's your periosteal dura. Keep it that blue color. Okay, then directly underneath your periosteal dura, you're going to have your meningeal dura. Again, you have meningeal dura forming that superior sagittal sinus. False cerebri. Okay. And then underneath your meningeal dura, you're going to have your, label that, arachnoid matter is directly under the meningeal dura. Okay, it goes all the way around. Coming off your arachnoid matter, you're going to have your trabeculae. just like normal. And as I said, those arteries that we talked about last class are going to be situated here in that subarachnoid space. So that's going to be an artery. Okay. And with the subarachnoid hemorrhage, that's no different than what we talked about that very first day of class when we talked about patient complaining of a really severe headache that just doesn't go away no matter what they do. That's called a subarachnoid hemorrhage. Now you know what where the arachnoid and subarachnoid is. And what happens is these arteries just rupture and cause the pooling of blood in the subarachnoid space. So here is arachnoid matter, and then here's your hemorrhage here. Okay. And on the right hand side, it's a normal situation where you'd have the normal pia matter tightly adhered to all the sulci and gyri of the brain. Where on the left side, if you start to have that blood pooling in the subarachnoid space, you get some compression of the brain and pia matter. Question? Yes. Hemorrhage. Yeah, that's your hemorrhage. So your bleed is it's called a hemorrhagic stroke or a subarachnoid hemorrhage. Okay. Yes.
Do the spines of the arachnoid matter are called? Do they help pull up the brainal and hold it together?
Say it again. What are the spines? The trabeculae?
Yeah, do the trabeculae hold up the brainal? That help?
No. The blood just starts to pool when you get compression. Yeah. So if it's a small bleed, then it's not as bad. You're not going to get a lot of neurological injury. But if it's a larger bleed, what happens is the blood pools so much so that this part of the brain can actually shift away from midline. It's called a midline shift, and then you really start having lots of problems. Okay. Depends on the size of the bleed. So the cause, we go back and look at the cause for a subarachnoid hemorrhage. It's going to be caused by a rupture of cranial artery. Okay. Could be due to something like an aneurysm. Does anyone know what an aneurysm is? Sorry? No, that's okay. It's okay. You don't have to answer. I'm not going to put you on the spot. Aneurysm, the best way to describe an aneurysm is like a little bubble off of an artery. Okay, if you can imagine, if you've ever seen a garden hose that gets stopped up, and then you have that bubble forming in the garden hose, that would be your aneurysm. So it's just like a built-up spot. It's a weaker spot that causes a bubble. Okay, and the most common place for an aneurysm is going to be your anterior communicating artery. Everybody remembers where that is, right? That's the little one that part of the circle of Willis that connects the left and right anterior cerebral arteries together. So anterior communicating artery is a common spot for an aneurysm, and that would be when there's an aneurysm in the anterior communicating artery. It's known as a berry, B-E-R-R-Y, just like blueberry, berry aneurysm. Okay, it's named berry aneurysm because when they look at it on the scans, it looks like a little berry hanging off the An aneurysm is something that hasn't ruptured yet, but has the potential to rupture. Questions? So the signs and symptoms. Is there a question, Ben?
So is the berry aneurysm specific to the anterior?
Yes.
pulmonary?
Yes. Very specific anterior pulmonary. Most common site for an aneurysm. Yes.
So when you're searching about leukemia, brain midline.
Oh, the whole brain shifts.
Yeah.
You can have a something called a midline shift.
Yeah, when the midline shift happens, do you think that would actually cause some seizures?
Oh no, push is very specific to posterior lateral thalamus. We'll talk about that next year.
Yeah,
Sorry, what are you
I was
saying?
just wondering if it was
Yeah, no, Pusher syndrome is specifically caused by a lesion to the posterior lateral thalamus, and it's a very unusual presentation. I haven't seen anyone with a brain bleed come up with pushers, but they can be pretty severe. What happens almost always when you have a midline shift or a large brain bleed is something called hypertonicity or spasticity. So, and we'll talk more about that next year. That's more of a clinical presentation. Okay. Was there a hand back there that somebody? No? Okay. Okay. Any other questions? Yeah, so we're talking, I'm not going to touch clinical rehab in here. That's next year. We'll get there. This is the basics of like neuroscience kinds of stuff, neuroanatomy. Okay, patient presentations. Okay, signs and symptoms. Remember the big one is going to be a headache. So that's going to be a big one, right? And you're also going to have neurological deficits depending on the site of the bleed, right? So depending on where the blood's pooling and what's being compressed, you're going to get neurological deficits. Neurological deficits, what is it?
They will pop up.
Yeah, thank you. That's what happens when I zoom in. Any kind of neurological deficit can happen. The visual changes, it could be sensory loss, or it could be weakness, or a host of presentations that we talked about. Okay, neurological deficits. And, since the blood is pooling here in the subarachnoid space, patient might actually complain of a stiff neck. Believe it or not, the treatment for this is just going to be conservative treatment. Okay, conservative treatment is they don't really do anything. They just wait and see what happens. And this is pretty common. And a bleed that's not super large, the person might present initially as having a lot of neurological deficits, but their prognosis overall is much better than anyone who's had an ischemic stroke. You can expect pretty good recovery within about 3 months, because what happens is that hematoma, or all the blood that's here in the brain, is actually resorbed and they go back, as opposed to what happens with an ischemic stroke is where that area of the brain has died. That's a lot different. Okay, so prognosis is going to be much better with a hemorrhagic stroke. Steph? Yeah. Or what's compromised. Yeah. Yes. Any other questions? Make sense? Okay, that's going to be your hemorrhagic or your subarachnoid hemorrhage. Now let's go ahead and move over here to the right side and look at the intracranial hemorrhage and start rapidly labeling. Okay. So these are two we can compare. So these are your suture lines. I think everybody hopefully has gotten the concept of the periosteal dura tightly adhered to the skull. And then underneath that you have your meningeal dura. Okay, these are all going to be intact. No changes there. Okay, and then underneath that you have your arachnoid matter. Again. Everything's good with arachnoid matter. Arachnoid matter has these trabeculae coming down, right, to maintain that subarachnoid space. Okay, and then underneath that you have your pia matter, which is tightly adhered to the sulci and gyri of the brain, the cortical hemispheres on both sides. Okay, so everything looks about normal, but what happens is there's just a small bleed somewhere in the cortical region. Okay, and the cause for this one, and we talked about the cause being the rupture of the cranial artery up here, but what do you think might cause the rupture of a cranial artery? I didn't write that part down. Does anybody know what's a big problem in the world today with that causes the increase of pressure inside blood vessels? Hypertension, yeah, HTN, yeah, hypertension, high blood pressure. Okay, that's what's going to cause that rupture. Okay. Now, the cause of an intracranial hemorrhage can also be hypertension. Could be something called an AVM, so that you've heard the word. AVM stands for arterial venous malformation. Okay, an AVM, and it's a congenital deficit where the arteries and veins come together. They form a tangle, and that tangle is more likely to rupture. Okay, so AVM is arterial venous malformation. It's arterio venous malformation. And you also have, this can happen in specific places. It can happen in the pontine arteries. Do you remember the pontine arteries, or those small little arterial branches coming off the basilar artery that we talked about? And it could also happen in something known as, this is a new word, and I'm putting it out there so that if you see it in the clinic, you know what it is. Lenticulostriate arteries. Okay, lenticulostriate arteries is something we did talk about last class, but in general they are small little branches like the pontine branches off the basilar artery that supply the basal ganglia with blood. Okay, so they're just lenticulostriate are arteries that you might see in someone's chart in your future. Okay. And the signs and symptoms for an intracranial hemorrhage are going to be a headache. And in this case, instead of just gross any kind of neurological deficit, they're going to be very focal. So in one particular place, because the bleed is going to be much smaller. Focal neurological deficits here. Okay, so just comparing and contrasting. So both the subarachnoid and the intracranial hemorrhage, the treatment is going to be conservative. Yes, Jonathan.
And you said the intracranial is just a bleed into the cord.
Just in wherever it is. What if it's a pontine artery? It's in the area of the pons. If it's lenticulostriate, it's in the area of the basal ganglia. Just a small little bleed. So here's your bleed right here. that's going to be your bleed. Just inside the cranium, in the cortical region itself, or the brainstem, depending on where it is. Okay, I think we made it through the meninges section. Let's move on to the ventricles. Are there any other questions about the meninges and all the different kinds of hemorrhages and hematomas? And so let's move on here. There. Let's look at the ventricles. The ventricles. Is everybody doing okay? Getting late in the day.
Do you guys remember the Chipotle is my life kid?
I'm fine.
Everybody's ready to fall asleep on me? Looks like it's a tough day. It's hard today. Worried about Dr. Blair.
Literally, it's
Out of energy.
What did you talk about in technology?
You had your head down. I was like, oh, she just ran out of food. She's like, okay, you ran out of energy.
Okay. All right. Good deal. All right. Let's look at the ventricles. Ventricles. Let's look at the lateral view for the ventricles. Okay. So quickly, what kind of section is this? If we had to say, if it's like straight down the middle, that's the sagittal section, right? Now let's go ahead and start labeling a few things. This is my friend's cerebellum. Okay, and then this is going to be the cortical region. But specifically, if it's a sagittal section, you need to be aware. I'm only looking at the left side. Okay, sagittal section. I've taken away the right. We're just looking at the left side. Okay, I like to look at the ventricles from a lateral view because I think it's the best way to see all the parts of the lateral ventricles. Okay, we'll talk about the different kinds of ventricles, but specifically the lateral ventricles, this gives the best view of all the parts of them. Okay? So here's your cortical region or your cortex. Okay? And then, your midbrain, your pons, and your medulla. Okay? So just a straight sagittal section. I'm going to start out with the third ventricle. Okay, you have two lateral ventricles. Those are number 1 and 2. We're going to start with the third ventricle because it kind of connects to a lot of different things. And then there's a fourth ventricle underneath in the pons. So let's start with the third ventricle. And for the third ventricle, I like to represent it here laterally as just a box. I'm going to try and draw a 3-dimensional box here. Okay, so realize this is just half. I'm only looking at the left hemisphere right now. So the right hemisphere has been removed. Okay, and this blue thing that I just drew, we're going to label that as the third ventricle. Okay, I'm representing the third ventricle there as just a box. The third ventricle in the upper top area has a special foramen or hole. I represent it here. Okay. In the topmost area, there's a special foramen, and that foramen is known as the foramen of Monro. Your foramen of Monro. And foramen of Monro is nothing more than just a small opening in the top portion of the third ventricle. Okay. Since you have a hole there, that means it's connected to something. And what it's connected to is actually the lateral ventricle. So the foramen of Monro connects the lateral ventricles to the third ventricle. Okay? And to draw that lateral ventricle, the ventricle here, as I said, so you're going to have a part here, and then there's going to be a part that comes off here in the front. So that part comes off in the front, and this part of the lateral ventricle that you can see really well from the side view is called your frontal horn. Okay, so if I told you that we're going to draw in more parts of the lateral ventricle, but if I told you that all parts of the lateral ventricle are responsible for supplying different areas of the cortical region, which lobe do you think the frontal horn is responsible for? Frontal, right. Just that simple. Okay, so we've got the frontal horn there, and then we come all the way back, and then we're going to have this other horn here that's in the back. Okay, that horn is going to be here, and this is called your posterior horn of the lateral ventricle. Okay, posterior horn of the lateral ventricle. And what do you think that horn is responsible for? Which brain lobe? Occipital, yeah. And then coming down. It's kind of tricky to. Oh, that's okay. You okay?
Yeah, I'm good.
Okay. So coming down off the posterior horn, you have, going to represent it here. You're going to have another horn coming down. Okay. And what happens is it comes up, and then it actually goes on the outside. So it's if you're looking at the left, and the third ventricle is here. It's more outside. And I'm going to try and represent that by a dashed line. So this means, this dashed line means nothing more than this horn is on the opposite side. Okay, and I'll have it come out there. Okay, that's going to be your inferior horn. Inferior horn of the lateral ventricle. That inferior horn there, and all we have to do is go ahead and complete the circuit. So we go up, and then over, and then this is the connection to that foramen of Monro that connects the lateral ventricle to the third ventricle. Okay, there's a lot of stuff to see that you can really see quite well with this section. Okay. And then the last part, you have all this part in the middle, really the bulk of the lateral ventricle. That's called the body of the ventricle. Let's just say body of lateral ventricle. Okay, all that portion in the middle. Okay, everybody got it? Yes, Chris Keller? Sorry.
Is the whole figure of lateral ventricle or the lateral ventricle?
That is one of the lateral ventricles. So this is the lateral ventricle that exists on the left side of your brain.
Okay, so the whole thing.
That whole thing is the lateral ventricle. That lateral ventricle has some parts to it, though. Okay? In the front, it's called the frontal horn. In the back, posterior, and then inferior horn. Those are all the parts of that one lateral ventricle. Okay? And that's going to be the lateral ventricle on the left side. Any other questions? See that? It's hard to, and we'll look at it, so right now we're looking at it from the side, and in a minute we're going to look at it from the front. Okay? You can't really see all those parts of the lateral ventricle from the front, as you can imagine, because it's kind of here. It's going to have a little more. But I want you guys to be able to see all the different parts of that lateral ventricle, and you can really do that best from a side view. Okay? All right, let's go ahead and move on. Let's look at, I want to do that. Yeah, let's look at, there's a hole here at the base of this third ventricle, and this particular hole does not have a specific name to it. Okay, it's just a hole at the bottom of the lateral ventricle, third ventricle, and it connects the third ventricle to the next part of the ventricular system. And this next part is actually one of my favorites. It's because it's a good landmark for the midbrain. It travels straight on down through the midbrain. Okay, it's just a connecting tube, if you will, from the third ventricle straight through the midbrain, and it is called the cerebral aqueduct. Cerebral aqueduct. Okay, cerebral aqueduct is nothing more than a channel through the midbrain that connects the third ventricle with the fourth ventricle. Okay, let's look at the fourth ventricle. Fourth ventricle resides mostly in the pons. Okay, so the fourth ventricle comes here in the back, and there's a connection to the back. There's going to be a special hole in the back that we're going to talk about here in a minute. Okay. And then it travels forward and then down like that. Okay. And then it makes a connection. There's a channel here through the middle of the spinal cord that's known as the central canal. Here, let's label this. This is the fourth ventricle. Okay, and then coming on down here into the spinal cord, you have your central canal. And that's nothing more than the hole down the middle of the spinal cord. You guys see that? Is that? Yeah, there you go. And like I said, there's a foramen, or a special opening here at the back of the fourth ventricle. And I like to remember this as there's only one of them, and it's in the middle. Realize it's a sagittal section, so it's in the middle. Middle Magendie. So this is the foramen of Magendie. M for Magendie, M for middle. Foramen of Magendie. M-A-G-E-N-D-I-E. Okay. Now, I'm only going to represent one, and I'll talk. So if I'm standing here and my head is where the cerebral aqueduct is, my foot going backward is the foramen of Magendie. It's going backward. Okay, that's in the middle. There's also two foramen out on the side that are lateral. Two of them. Okay, L for lateral, L for Luschka. So I'm going to draw one of them since we've lost the other side. But I'll represent it going back. We'll see it again from the front here. But here's another foramen that you need to be aware of. Okay, that's your foramen, and there are two of them, but I'm only going to represent one here because we only have one side. That's your foramen of Luschka. L-U-S-C-H-K-A. Foramen of Luschka. We'll talk about the importance of those foramen as we go forward. Questions? Are you guys good? You sure? I don't mind answering. No? Okay. Yes, Ben's got a question.
I'm not sure if I missed it, but what are the little dots on top of the frame and
Oh, that's, I'm trying to represent, so what you're seeing is only the left half. So if this is the frame and Alushka over here, I'm representing that it's on the other side,
Okay.
going through.
Okay.
Okay, so you can't see it, it's on the other
So
side.
it runs medial and lateral.
Medial left, let me look at that and see if I'm, yes, I know, I think of it, yeah, yes. Okay, so yeah, if you're looking at it straight on, this is what you're seeing. These are Lushka, and this is Majendi back here. So we have orthodox up here.
Got it.
Huh?
Thank you.
You're welcome. Any other questions? Well, like I said, this is the view from the side. Here we're going to look at the view from the front in a minute. Okay, yes, Alex.
The third and fourth ventricle don't have names. They're just third and fourth.
They're the third and fourth ventricle. Yeah, there's nothing special except for the foramen majendi, foramen Lushka. That's all you need to know about that. We'll talk about the function of those foramens here as we go forward. But I need to give you guys a 10-minute break.